Good afternoon, ladies and gentlemen. I'm Captain Chip Dettra, the Airline Pilots Association Chairman of the National Aeromedical Group. Aeromedical Group makes up one of the 5 components of ALPA's pilot assistance structure. In the Aeromedical Group, we take a multifaceted approach to helping members maintain good health with information and individual interactions. Our group works with the medical industry and federal regulators to ensure the latest information and standards not only get to the pilot, that they receive the information, but it's also applied to their medical certificate. Now on to our panel. I'm very honored to have such distinguished guests today. Dr. Quay Snyder is ALPA's Aeromedical Advisor, and Dr. Fred Tilton is the FAA's Federal Air Surgeon. Following their presentation, there'll be ample time for questions, and I encourage you to engage Dr. Tilton and Dr. Snyder, and so make your way to the microphones with your questions. Dr. Snyder is the President and CEO of the Aviation Medical Advisory Service. We often refer to it as AMAS. ALPA and AMAS have a critical ongoing relationship that started in the late 60s. Every airline pilot must pass a regular medical examination to determine his general health and fitness for duty. AMAS assistance is invaluable not only in helping pilots maintain their medical certificate, but in helping pilots regain their medical certificate with the least amount of hassle in a reasonable amount of time if it were ever to be denied. They also provide proactive information and assistance that ensures pilots maintain the best possible health throughout their airline career. Dr. Snyder, I'd like for you to talk about the scope of your operations over there and how AMAS supports ALPA.
Thank you very much, Chip. It's a pleasure to be here. The ALPA Aeromedical Office was formed in Denver in 1969. And since that time, we've been providing services for ALPA, its members, and its leadership. We've also been interacting with the FAA and with international organizations, the military and the NTSB, with the goal of promoting pilot health and pilot safety. We have 2 primary functions that we work with. One is the consultation, which is advice to the union leadership on issues such as what you will find out in the white papers that have been distributed in the back room. Please pick one up and take a look at that as they cover some very important issues. The other part of our services are to the individual pilots. We assist them with maintaining their health, providing them advice about how to best do that while simultaneously helping them maintain their medical certification and be compliant with the FAA rules for reporting medical conditions. We work closely with the Pilot Assistance Committee, which Captain Dettra alluded to has 5 components. The aeromedical, but we also work with the HIMSS, which Captain Moak spoke about earlier today, a program where pilots with the disease of addiction or abuse are successfully treated and returned to the cockpit in a very, very successful program. We work closely with the professional standards and critical incident response teams from ALPA with pilots who may have problems in different areas, and many times we find overlap from all of those areas. The Canadians also work closely with us, although they have some autonomy and some different regulations that apply to them. The common theme of health and safety is universal for all pilots. We also spend a considerable amount of time interacting with the ALPA's Engineering and Air Safety Department to take a look at areas where pilot health might be improved through broad areas with suggested changes in technology and regulations. Our other interactions include the legal department and retirement insurance to make sure that pilots are encouraged to get the appropriate medical care and have the ability to do so. A big part of our efforts also are working jointly with the communications department at ALPA. We write monthly articles, Health Watch, to inform pilots about evolving technologies, current medical conditions, and how best to care for themselves. We also produce some short segments for TV. Captain Dettra produces the Aeromedical Flyer, an information handout that goes out to all pilots. And we have other opportunities to communicate health and safety information to the pilots. We also participate in a number of conferences, the premier conference being our HIMSS conference, which is hosted in Denver every year with about 300 to 350 attendees. Our international activities involve cooperation and coordination with international pilot unions and the certification authorities, such as in EASA and the ASEAN countries. We do have a relationship with the ICAO medical office and Dr. Tony Evans there. And our HIMSS outreach also includes educating our international brothers and sisters regarding programs to better treat the drug and alcohol problems. Most recently, we've been in New Zealand, Hong Kong, and Brazil to assist them in setting up programs. Perhaps the most satisfying portion of what we do is collaborating with the Federal Air Surgeon's Office in a host of areas. Dr. Tilton's been very gracious in working with ALPA, as you've seen all day with the theme of cooperation between industry and regulators. We also work very closely with the Aeromedical Certification Division in Oklahoma City, primarily on behalf of individual pilots, but also to initiate and effect policy changes. Some of the areas that ALPA has been pushing for changes in policy that have been great successes are, number one, the HIMSS program with over 4,000 pilots who have been successfully returned to the cockpit. Back in the 70s, coronary artery disease was a disqualifying condition, and what that did was drove pilots underground to not report conditions or, dangerous to their health, not seek evaluations and treatment. But with the evolution of policy changes in that area, now pilots routinely are returned to fly after being successfully treated with these diseases. Other examples would be the HIV seropositive pilots. In interest of the transmeridian travel that we do, Dr. Tilton's office has worked very closely and announced policies that allow pilots to use sleep medicines to better prepare our pilots and make them safer when they are faced with these transmeridian flights and are facing the jet lag or circadian desynchrony. A very, very important change in April of 2010 was a policy allowing pilots with the disease of depression to fly on certain medications with aggressive monitoring and testing prior to doing so. When the SARS epidemic broke out and we had H1N1, there were questions about whether pilots were at risk for the diseases and whether they could prophylactically use medications to reduce their risk of disease, particularly if they had symptoms. The Federal Air Surgeon's Office was instrumental in announcing policies that allowed our pilots to fly with the protection of medications, and that was done in a matter of several days. Flight time, duty time has been an ongoing discussion, and I think we're making significant progress. The medical aspect looks primarily not only at the science that has been so well defined, but also ways that we might augment that. And we also provide education to the pilots about other areas that might help, such as the use of nutritional supplements in lieu of medications, and also discouraging the use of alcohol and over-the-counter antihistamines, which many pilots have used in the past. Some of the current issues we have are the evolving technology and products in medicine. There's a continuous evolution of medications that are coming out, but also now we're looking at pacemakers that have interesting capabilities now, automatic internal defibrillators, perhaps the artificial pancreas for individuals afflicted with diabetes requiring insulin. On October 1st, the FAA is implementing universal web-based medical applications for pilots. We've been able to work jointly to understand some potential problems that both pilots and air traffic controllers might face. With the ultra-long-range flights, Again, we've worked with circadian desynchrony issues and the medications. The laser hazard exposures, the Vision Research Department within the Civil Aeromedical Institute was instrumental in providing us information that allowed us to educate the public at the Laser Hazard Conference that ALPA hosted last year. We're continually interested in streamlining the certification process for our pilots so that there is less reluctance to get treatment and report conditions to the FAA and know that once they are medically sound, they can also be certified. And in the very, very near future, I think we will be wrestling with commercial spaceflight medical standards, not only for the crews, but possibly for the passengers as well. I earlier mentioned the ALPA white papers. I would encourage you to pick up a copy in the back near our sponsors. One of importance is enhancing pilots' occupational safety and health protections, which encourages an aviation health and safety partnership program with the FAA, with industry, with OSHA, and with pilot groups. There is also another white paper on unmanned aircraft systems. The medical certification of the operators of those systems will be a key issue for discussion in the very near future. We're very, very fortunate to have Dr. Fred Tilton, the Federal Air Surgeon, with us speaking today. After graduating from the Air Force Academy, from the West Point, I'm an Air Force guy, so, sorry. He did come to the bright side and join the Air Force and had 4,000 hours as a command pilot and a senior flight surgeon in a host of aircraft, including the B-47, C-141, trainers, T-37, T-38, transport aircraft with C-12, and in his last assignment in the F-15. He's a graduate of the University of New Mexico with his Master's of Science and his MD, and has his Master's of Public Health from the University of Texas. After retiring from the Air Force, he had a career as the Regional Medical Director for Boeing Aircraft Corporation and then became their Corporate Flight Department. He took his initial position with the FAA in 2000 as the Deputy Federal Air Surgeon, and since 2006, he's been the Federal Air Surgeon. And currently, he flies the Citation XL for the FAA. Dr. Tilton is a friend, a colleague, and he is a pilot's doctor or a doctor's pilot. He understands aviation, he's an advocate for the pilot, and it's a great privilege to have him speaking with us today. Thank you, Fred.
Hello, everyone. I usually tell people when I get an introduction like that, it just proves I'm really old. So you're fortunate that you have Dr. Quay Snyder working with you. We work with him every quarter. He comes to Washington with one of his staff members, and we spend a significant amount of time discussing policy, and then we look at individual cases so that he represents you and your constituents and makes sure that if we're having problems with certifying individuals that they get the best shot. And so he does an outstanding job for you, and you're fortunate. I'm only going to take a couple minutes to give remarks because I want to give you most of your time to ask questions. But the first thing I want to talk about is a certification policy that we have at the FAA. As you heard, I was a pilot before I was a doctor, and I used to tremble a lot when I used to go see my flight surgeon thinking that the best thing I could do was break even. So if I could get in there and get out of there and he didn't do anything to me, that was a good thing. So I felt that way until I was flying B-57s when I flew at a special squadron, and our squadron flight surgeons were assigned directly to the squadron, and they flew with us. They went TDY with us. They went to the club with us. They did everything, and I learned that the best flight surgeons are the people who integrate with the pilots, work closely with them, party with them, socialize with them, and realize that flying is extremely important. And I always tell people that a flight surgeon can make a big mistake if he unnecessarily disqualifies somebody, which we hate to do. So that leads to our certification policy, which is, as you well know, I work in AVS, aviation safety in the FAA. I work for Peggy Gillian, who spoke to you earlier today. And the primary reason we're there, like the reason you're here, is for safety of the airspace. So I tell everyone that I work with, The reason we're here is to make sure the airspace is safe. And I go to AME seminars and I talk to them all the time about the primary reason they're there is to do the same thing. And in fact, you probably see your AME more than you see any other FAA person. And so the AME has a great opportunity to talk to you about your history and to make sure that you are safe and to learn new things that we're finding out in aerospace medicine. But if you take for granted that the primary reason we're there is for aviation safety, the second reason we're there is to make sure that everyone we can get in the air, we do. And if you look at our history at the FAA over the years, 40 years ago, if you had hypertension was being treated like I do, and you had a lot of other things, you were disqualified, not just for a month or a year, but forever. So we have gone a long way, and if you look at the list of things we certify now, 40 years ago, they would never have considered doing that, and we do that based on evidence-based medicine. If we look at a way to find someone that can safely be certified, even though they may not meet the standards, our primary mission is to get them in the air safely. And our data show that. We denied less than 400 people finally last year. And the data are a little bit skewed because those are the people that pursued it all the way to the end. But we deny very, very few people because our primary philosophy is certify everyone we can and get them in the air. The second thing I want to talk about is the Pilot's Bill of Rights. You may or may not be aware of it because it was just passed recently. And I'm not really sure, nor is the rest of the FAA, exactly how that's going to impact us. But it will impact us because now we're going to have a requirement to notify pilots when they come in for their medical exams that they're having an examination which is, according to the law, an investigation. So what will that mean? It also means that they have a right now. They used to be able to appeal beyond me to the National Transportation Safety Board. Now they can appeal into the U.S. District Court, which means they can get a jury trial. All of these things, and there are several aspects of the Pilot's Bill of Rights that we're not clear exactly how they're going to affect us, but they will affect us. They will affect you. So in the coming months, you'll learn more about that from flight standards and from us as well, and probably from your legal advisors at ALPA. So be aware that it's coming, and there's more to come in that regard. And with those comments, I'd be happy to sit down and answer questions or stand up and answer questions. Thanks a lot.
Dr. Tilton, we really appreciate you coming today. My question has to do with attendance and reliability policies, specifically at regional airlines. I was at Colgan Air before I left a few months ago for my current job, and in 2008 they implemented this policy where a pilot who calls in sick because could be disciplined if he does it quite a few number of times throughout a rolling calendar year. Then we had our accident in 2009, and the company suspended the policy. A couple months ago, before I left, they continued once again to implement the attendance and reliability policy, which is in direct conflict to our medical standards. It's a policy that really conflicts with the FAA guidance about pilots flying sick. And I know my former airline isn't the only one that has this policy. What are your thoughts on that, and is the FAA looking into these individual airlines that do have these attendance and reliability policies?
Well, first of all, if you have issues like that, medical probably is not the correct organization. It would be flight standards that would be looking at the management of an airline. I certainly do not think that it is a good idea for people not to be able to tell their airline they're sick. I said at the outset, my primary reason for being here is aviation safety. And if someone is telling you you're sick and you have to fly an airplane, it's counter to the philosophy for many reasons. I would not support such a policy, but in effect, we don't make policy for the airlines. They do that. And so if you feel there's a conflict with your airline that they're causing a safety issue, you should report it probably to flight standards and not medical, although they might talk to us about the consequences.
Really appreciate that. Thank you.
Deferring to the illustrious captain.
Thank you, Dennis. Yeah. Good afternoon, Dr. Tilton. Bill DeGrow, Aircraft Design and Operations Group Chair. I had actually a couple questions. From your perspective, we have some emerging technologies coming our way. UAS is one that was brought up on the slide. And I wonder if you could elaborate a little bit on thoughts of aeromedical issues that might be unique to UAS. That's one. And then the same kind of question with ultra long haul operations. In particular, I've had a couple bouts with kidney stones, and I don't know if there's an airline pilot out here that hasn't had a kidney stone. I didn't know if there was any more information along that. I know my AME has joked often about wanting to start a research project and why that's such an issue with pilots. But just those two questions about aeromedical challenges faced by perhaps UAS and ultra-long operations.
Well, I'll start off, first of all, by saying I hope there's at least one airline pilot out there that hasn't had a kidney stone. And I don't know if there really is an increased incidence of kidney stones in pilots, but I do know that one of the reasons people have kidney stones is because they get dehydrated. And sitting in an airliner at 7% humidity for ultra-long flights, as you just talked about, sometimes 18 hours, even longer, if people aren't hydrating themselves, there's a possibility they get dehydrated, and if they have a potential already to have a kidney stone, that might exacerbate the problem. I don't think anybody's really done a study that says that pilots have kidney stones because of that, or that they have an increased incidence of kidney stones. But certainly it's significant, because if you have a kidney stone, those of you who have had it will tell you that it's not something you want to have in an airplane. And they're extremely painful, and they're something that we watch, and certainly we have lots of people that have waivers with kidney stones, but we're concerned that you might have one in flight that might pass and create problems. Now I'll get back to your first question, which is what are we doing about UAS, and what do I think the aeromedical situation with respect to UAS? We are actually looking to develop standards for people that operate UAS. The problem is there are so many different kinds of those airplanes that are flying. Some of them are the size of a bumblebee, and some of them are getting up to the size of almost a 737 or bigger. And how do you deal with those individuals that operate those? Some are actually doing them by line of sight, where they're watching these and they have an observer that watches them. They may be inspecting a building. Some of them are flying on computer programs. And so we have all kinds of issues associated with vision, associated with hearing, associated with cognitive functions and programming. And as you're well aware, some of them are fly completely programmed, and they program and take off and land, and you don't do anything else. Some of them are flying like model airplanes, where actually in visual control. And there are other ways that you can control these airplanes. So we are going to look at, and the FAA is actively trying to figure out how we will develop medical standards, and we're working on rules to do that. Right now, we have no authority to regulate those with respect to medical conditions, but I think eventually, and I don't think eventually means a long time, but it's going to take us months or maybe a year or two to figure out how we develop a standard that covers this whole gamut of UAS, from very small things to very huge things. How do we deal with them in the airspace? How does air traffic control do with the way we used to manage airplanes, which is see, be seen? Because there's no one in a global hawk to see outside. So it's an issue for us in medicine. It's an issue for air traffic control. It's an issue for you as pilots. It's very complicated, and so I expect that you'll see in the coming months some standards associated with those people that operate them. But how we'll end up completely, and finally at the end of the day, I'm not completely sure.
Thank you very much.
Oh, boy, I'm the last guy standing. I get to ask the big question. First of all, I'd like to say, as a recipient of a special issuance medical, thank you very much. That was a wonderful thing to get that medical back. And I'd like to congratulate you folks for the speed at which the process moved. I was quite surprised, pleasantly surprised. My question has more to do with, as we in the Aircraft Design Operations Group look forward, we hear manufacturers talking about constructing single pilot transport category airplanes and things like this. And I just wondered what you look at in medical standards as you would consider that type of development. This is much way down the road type of a project, but as we look at the looming potential looming pilot shortage. There's two things I see coming. One is single pilot transport airplanes, and the other is perhaps pilots flying well past age 65.
Okay, single pilot is an interesting issue, and actually pilots in the United States have less of an issue than they do in the United Kingdom, in Europe, and even in Canada. And the reason I say that is we do not certify individuals that we feel may have some kind of medical problem that will create a problem, a safety problem in the air. The Europeans and the Canadians, and I'm not sure about the rest of the countries in the world, have programs where they will certify one that says only for participation in a multi-pilot cockpit with a fully qualified co-pilot. We don't do that. So we certify people so that we believe that they're just as safe to fly an airplane as someone who might not have a special issuance or a waiver. So as a result of that, from the medical perspective, I don't think that having a single pilot transport airplane is as big an issue as I do think maybe from the flying public, who wonders about one pilot up there and what happens if that person has some kind of medical problem. And as you're aware, when we frequently see pilots that get incapacitated, not because they have a condition that's disqualifying, they may have a gastrointestinal problem or something that affects them temporarily, where 2 days from now they're ready to go fit and fiddle. Yet, if they'd been alone in the airplane, what would that have accomplished, and how would that affect the safety of the airspace? I've actually heard of some manufacturers that were developing single cockpit airplanes and decided that the public wasn't ready for those kinds of airplanes, and that's anecdotal. I'm not sure if that's true or not, but I think with respect to your question, how is it going to affect medical? Not so much in the United States, more so in Europe because of the way they certify people. Does that answer your question?
It sure did. Thank you again.
You're welcome.
Thank you. Good afternoon. My name is Bob Perkins. I do not have a kidney stone. I'm the Air Safety Coordinator for Canada, and I'm also the ALPA AGE Chair, and I'm more interested in the international certification. The idea, of course, is to try and globally harmonize as much as possible the certification standards through ICAO and EASA and other bodies. I'm just wondering how the FAA is cooperating with, which venues they're using to work with Transport Canada, to work with EASA, to work with ICAO on that harmonization of medical standards, or if there is in fact a harmonization.
It used to be, in my opinion, better than it is now. And the reason I say that is shortly after I came to the FAA as the deputy, the JAA, essentially the chief of standards, came over and visited with us and said, couldn't someone from the FAA please come and help them develop their medical policy? And at that time, the JAA, or the Joint Aviation Authority, was struggling through how were they going to create their medical standards in Europe so that they get to one voice, so that they could then input that to EASA. And that committee met quarterly, maybe sometimes only 3 times a year, but usually quarterly. And I went over there as the participant in that committee, and I sat through those meetings. I learned a lot. And I learned a lot about their philosophy versus our philosophy. And essentially, the standards in Europe are not that much different from the standards in the United States. The difference is how they employ those standards. And so now that the JAA has gone away and now EASA is the legal body managing the medical certification issues, I don't participate so much. I participate more now with ICAO than I do with the EASA folks, and they also come to the meetings. So there is a committee set up at ICAO that's called the Medical Program Study Group, and we go up there and discuss standards, look at the ICAO standards, and try to develop a uniform ICAO standard, which then we hope will get deployed across the world. So rather than working directly with EASA, I'm working more closely with ICAO to develop the standards. And as a matter of fact, related to that, you may be aware that on the 20th of July, a rule was finalized that pilots who have a special issuance no longer have to carry their authorization letter along with them. And the reason we got that requirement was in 2007, ICAO audited us, not the medical part of ICAO, but they audited the FAA, and they actually forced us to write a rule that said, if you have a waiver, you must carry your letter of authorization with you detailing the reasons you have that waiver. At first, they wanted us to put that directly on the medical certificate, and we said, there is no way we're going to do that. So they allowed us, as an accommodation, to carry the authorization letter on with them. Shortly thereafter, the ICAO doctor called me and said, why did you do such a dumb thing? And I said, because the auditors told us we needed to do that. And we worked with him over the years and finally got an agreement from ICAO that it wasn't necessary to do that. So pilots, whether they're private or commercial, no longer have to carry that letter with them. And the reason that was such an issue is because it had privacy information on it, what their diagnosis was, et cetera. And so having to show that to an inspector was not necessary, we believed, because all they needed was a medical certificate that they're medically certified to fly. So I think that's a good thing, and that's one way we're working with the international folks to make flying safer and healthier and easier for you.
Thank you.
Hello, Bob. Dr. Tilton, Linda Orlady, a former ALPA safety volunteer, now working for Boeing as a flight tech and safety pilot, talking with an airline pilot about a month ago who received an email, I believe from your office with your signature, about a survey about AMEs. And I was curious, I assume you're familiar with it, but I was curious in terms of its objective, if you have the results back, are we looking to change AME standards, or what were you hoping to gain?
We don't have the results back yet, and yes, I'm aware of that. It's actually run out of our office in Oklahoma City.
Yeah.
They do that every 2 years, and what they're looking at is to get a consensus of what AMEs are thinking, what their issues might be, do they have suggestions about how we can do our business better. So not necessarily changing the AMEs business, but much more making how we can make them more effective. And where can we change policies so that it'll make it easier for them to do their job, and as a consequence, easy for them to help you get certified and get your medical certificate.
Thanks. Is there one particular challenge that seems to be, one area that seems to be the largest challenge for them getting pilots back recertified?
I wouldn't say there's one particular challenge other than what your earlier speaker said was he was thankful that he got his clearance so quickly.
Yeah.
We worry about that a lot. In fact, we just lost the person who's run the certification division for over 15 years, Warren Silberman, who's been now replaced by another individual named Courtney Scott. But he and his staff look at that closely. One thing we've done to enhance our abilities to do certification quickly is we've now expanded certification to the regions as well. So a pilot can talk to their regional medical director, so can an AME. And hopefully that business of looking the way we do certification, making more expeditious and enhancing our ability to do that quickly yet safely is one of our primary goals.
Well, good. No, and Quay, I know certainly your group and the resources are superb with that. Have you noticed much change in the process? The impression I get from talking through folks is that it's, I don't know if I'd say easier, but just better or more clear or less ambiguous. So I think somebody's doing some good things.
I will make one other comment, and one of the things that we're doing is looking at a way we maybe can do away with some special issuances. If a person has a particular issue which is stable, some kind of cancer, for instance, although they've had cancer, it's now been, quotes, cured, although people are now saying if you have cancer, you're not cured, you're just living in some kind of state where it's possible it could come back in 30 or 50 years. Mm-hmm. But if you're stable, and we believe a person is stable, and we're asking for the doctor to give us a report every year, and the report comes back and essentially said, I told you he was okay last year, why are you bugging me? There's no good reason for us to do that. There's no good reason for you to have to get that report. Perhaps you, if you're being followed by your oncologist or your cancer doctor, he or she can do that and give that to your AME, or perhaps your AME can make that decision. And instead of requiring those people to have a special issuance, we'll just issue them with a regular issuance saying you have this history, and if you have a recurrence, you need to let us know. So hopefully that will, again, streamline or help streamline the process that we have for certification.
That's appreciated. Thank you.
If I may comment, there's numerous examples of the Office of Aerospace Medicine streamlining the process, reducing the requirements for observation periods or the documentation. Most recently, we've seen a substantial reduction in the processing time for pilots diagnosed with sleep apnea, which may affect 4 to 6% of the US population. It's a very dangerous condition and certainly has adverse effects on aviation safety. Yet the initial certification process required a series of tests that were both expensive and required a long period, relatively long period in between getting the test, getting the data, and getting it to the FAA. So it discouraged pilots from obtaining evaluations for a possible serious medical condition. Now that the FAA has shortened the process to allow technology to take advantage of getting data quickly, the process has gone from what used to take 3 months to now sometimes under 2 weeks. So it works synergistically with the pilots to improve health, and as Dr. Tilton said, the safety of the airspace system, because pilots are encouraged to pursue these evaluations to get treatment for diseases they might have.
Hi, I'm Colin Wilson with Mesa Airlines. I'm ALPA safety volunteer, and I've got kind of a three-tiered question here. First of all, we hear all sorts of wild accusations or claims as to the amount of radiation that we are exposed to on certain stage length of flights. So one, could you kind of give us some kind of idea of what it may be equivalent to in other aspects of our lives? And then kind of go into possibly if the solar flares that we're seeing so much on the news these days is adding to that exposure. And that kind of segues into my final part. Could you discuss the interactions that you have with other aviation safety and health organizations, such as the CDC and TSB, maybe even NASA?
I'm not an expert on the first two questions, but we actually, unfortunately, the person who used to run that organization named Wally Friedberg just passed away last week. He was an internationally recognized expert, and he actually developed an algorithm that could look at things like solar flares, determine whether or not an airplane should be diverted based on the proton, the probability that a proton storm might cause some problem. So we actually have an algorithm that you can use to look at those to see if airplanes need to be diverted, and we actually have done some studies looking at certain kinds of cancer to see if they are caused by exposure in the cockpit. There's one particular kind of cancer called melanoma, which there may be some relationship with, but I don't have the data, and right now it's anecdotal. Certainly, if you're at altitude, there's a possibility that you're exposed because the higher you go, the less atmosphere you have protecting yourself, and so there's a probability that you'll be exposed. You are protected somewhat by the cockpit windows, and there are some issues that we don't have all the answers for. I haven't seen any significant increased risk with respect to the numbers saying that if a person is exposed in an airliner, he or she has this much greater risk of having a particular kind of cancer. There is a relationship to melanoma, and Quay may have some more data on that, I don't know, but I have no more data than that. Now, the last part, and then I'll let Quay answer the question if he wants to, is that we interact with some of the other safety organizations. I'm on an oversight board at NASA, actually, for their medical committee. So when they have significant issues, they will call this board together, and we meet to discuss their policies and hopefully help them develop their safety standards that then they implement at the FAA. And there are members on that from the military and from the private community. There was a member on there from the National Transportation Safety Board. Other than that, with respect of interactions with individuals like Quay, we do interact with EAA and ALPA, and they, in fact, I was at Oshkosh a couple weeks ago and met with their medical oversight committee that helps them, and they're a group of AMEs that help them deal with pilots that have significant medical issues to help them deal with their problems. And so I frequently get calls from the chairman of their medical committee, and I also get calls from Gary Crump, who's the ALPA medical director whenever they have issues to deal with us. And those individuals also interact with the regional flight surgeons and with the medical certification division in Oklahoma City to deal with particularly difficult medical certification issues. And now, if Quay has a comment with respect to the cancer issue, certainly welcome.
Be happy to. There are 3 studies that I'm aware of. We've looked at a study from the Medical University of South Carolina that looked at cancer deaths, and essentially pilots were a healthier cohort than the general population in that. There was an increased incidence of melanoma, but it wasn't clear that that was caused by radiation received in flight. It may be that pilots have easier access and more leisure time to get to warm climates where they might be exposed to that. So the cause and effect was impossible to determine. There was one study where there was an increased incidence of a rare type of brain tumor in pilots in Canada, but it lacked the power because of the low numbers to really make an association of that. And there was another study of flight attendants in Scandinavia, I forget which country, which may have shown a slight increased risk for breast cancer. But we really don't have any hard evidence for that at this point in time. There are 2 issues. Dr. Tilton mentioned the resources that the FAA has to calculate out radiation doses that Wally Friedman did. And that's called Carry 6. It's available on the website. And I know ALPA and the Allied Pilots Association have folks who are looking at radiation issues. Also, the white paper that I mentioned earlier looks at possibly tasking the airlines with monitoring radiation dosages, much like a radiation type worker would wear a dosimeter. For the individual pilot, though, those answers are not satisfactory. So we're confronted with a situation where people may ask us about what to do. The person who's at highest risk is the pregnant pilot in her first trimester. And that's an individual decision about whether she should fly or not, but there are certain strategies that we recommend that people would take if they elect to continue to fly. That woman should probably fly at the lower latitudes because of the greater shielding from the ozone, and also fly at lower altitudes to get more protection too. So the short duration flights in the southern latitudes, if they can bid those, would be a significantly lower radiation exposure than someone doing a transpolar route. So on an individual basis, that's the information we can give now. Hopefully at some point in the future, there'll be actual dosimeter ratings and we can compare those to radiation workers.
Good afternoon, gentlemen. I'm Kevin Hyatt, the COO of the Flight Safety Foundation. In the opening remarks there, Dr. Tilton, you had talked about evidence-based medicine, and that piqued my interest because in the safety world, we're all interested in evidence-based training, those types of things. I was wondering if you might be able to go into it just for a few minutes about what that means as far as evidence-based medicine, who's collecting that data, and how are you using that data to help us as pilots?
The way we collect that data is getting information from just general studies on various kinds of cancers or various kind of medical issues. Effectively, if you could look at heart disease, for instance, and as I said in my earlier remarks, 30 or 40 years ago, if someone had high blood pressure, they got disqualified. If they had a heart attack, they got disqualified. If they had even a heart transplant, they got disqualified because we felt the risk, and our primary concern that we have is looking at catastrophic risk. I tell people if I could figure out if somebody has a particular problem and I could safely certify them for 6 months and then they were going to fall over dead on 6 months and one day, I would certify that person for 6 months. The problem is there's a lot of art in the business and it's not all science. But what we can do is we can look at particular kinds of cancer and say that the most likely problem with that will be maybe a spread to the bone rather than to the brain. And that's the big problem, because if a cancer spreads to the brain, sometimes the first time we know it's there is when they have a seizure, which is not a very good thing to have in an airplane. So we look at the data, we try to determine what kind of problem a particular person might have, and we do this based on looking at the literature. We also look at our cohort, which means our people, our pilots, and see what they have, and see if we can gather any experience. Now, you asked who's collecting the information. We have millions of records that we've been certifying over the years. The problem is that our database is not what's called a relational database, so it's difficult for us in some ways to go through that database and pick out particular issues, although we're getting better at it. There's a medical information system in the FAA, which is really a collection of medical information systems, not medical information systems, called a SIAS, which is collecting over 70 databases and putting that together to look at accidents to see if there's a way we can prospectively look at accidents. We have a similar database in medical, which takes the database I told you about and then looks at it to determine whether or not a particular medical condition could create an accident. And the first clear data that we got that we did that with was with a particular condition called atrial fibrillation, where they were able to get the data, glean it to make sure there weren't errors in the data and it was clean, and then determine that a person with atrial fibrillation treated a specific way was cleared to fly. And we're looking at doing that with other conditions to make sure that when we certify someone, we can do it safely, but also to allow us to certify more people that we might have disqualified in the past.
Very interesting. Thank you for your comments.
Hi, Jason Hilde from Alaska Airlines, CRP volunteer. I was wondering if you would promote a policy which, instead of having an arbitrary age 65 retirement, would instead depend on an individual examination as one got older past the age 65.
Excuse me. The reason I cough, not because of your question. I cough because I've been coughing for several weeks. In fact, when I told Quay, he says, you should see your doctor. And I said, I did see my doctor. In fact, he's my AME, and he told me to take some antibiotics, which I'm doing right now, but still coughing, so I apologize for that. But refresh me again what you asked. 65. 65, yes. It's working on my brain, too. So we had a big problem with age 60. And the reason we had that is there is a specific ruling in the FAA that says if you have a safety rule, in order to change that safety rule, you must prove that it's as safe as or safer than it was before. So we had a difficulty trying to get to age 65 for that very reason, because while it looked like with people that are living longer and aging slower and seeing people that were dying later on, and you look at longevity, that people could safely fly an airplane up to age 65. And I think as we go beyond the law that changed age 60 to 65, that we demonstrated that it was safe to do so. But it was done so at by Congress passing a law. Now, if you ask me, should we change from 65 to 70, the problem is that people have two different kinds of age. They have a chronological age, which means they go from 1 to 2 to 10 to 50 to 90. And they also have a physiological age. And there are some people that should be safely flying, could be safely flying up into their 80s. In fact, we have lots of people that are certified over 80 that are flying privately. And Canada, I mean, soon Australia actually doesn't have an age restriction, although they're pilots that can't fly internationally unless they fly into a country that allows them to do that because they don't meet ICAO standards, which also has age 65. So if I could figure out a way to measure someone's physiological age, then I would certainly say I would support them flying beyond age 65 commercially. The problem is that I might also be finding somebody that over the age of 35 shouldn't be flying physiologically, which also would create a problem. So it's, again, some art arranged with the science, and I don't know how to do that to support it other than the fact that possibly in the future, when we're looking at people, looking at their longevity, looking at what kind of medical conditions they get, making sure that physiologically they're okay to fly beyond that, then we could, again, figure out a way to maybe go beyond age 65. But right now, we don't know how to do that.
At the time of the age 65 debate. I know ALPA formed a blue ribbon panel to take a look at it. Linda came out to our office and we had some discussions there. There were two issues. One was the risk of sudden incapacitation, such as a heart attack, a stroke, a seizure, or any other event. And the other was the issue of subtle incapacitation. When you look at the data, and Flight Safety Foundation in Aero Safety World published the most recent paper that I saw, you find that the risk of sudden incapacitation really, for the most part, is age independent. The largest group of incapacitations would be, as Fred said, it could be ear, nose, and throat or GI. The seizures can happen with any age, depending on them. Heart attacks, sure, they happen in older folks. Those are, you're able to test for them medically, but from a public health perspective, the number of false positives you get in an asymptomatic population doesn't justify testing that group of people. The bigger worry was the subtle incapacitation. There's a perception that there's cognitive decline. Actually, it's not a perception, it's a fact that there is some cognitive decline with aging. And you gave me a good study or good paper on that from a gentleman from the Naval Aeromedical Institute who had done that. The question is, where do you draw the line and do you do testing? And does the testing that's available give you relevant aeromedical cognition information? And our recommendation was that the training process was a better proxy than doing testing on individuals because of the variability. And as Fred said, if you instituted that as a requirement, you would have some 35-year-olds who wouldn't qualify. They wouldn't meet the cognitive standards, where you could have people who are 75 or 80 years old exceed those standards. So it was a very difficult situation. I was very pleased to see that the FAA essentially kept the standards identical to what they are. And there are airmen who are 80 and even in their 90s who hold a first-class medical certificate. The age 65 restriction is a safety restriction based on operations rather than on a medical issue.
Good afternoon. Mark Pinsky, the Delta ALPA Aeromedical Chairman. I work closely with Dr. Snyder, and I just wanted to pass along my sincere thanks for much has predicted the success of the SSRI ruling. It's changed lives. I take phone calls on a regular basis. I wanted to point out the law of unintended consequences, and while I know of 2 at Delta who are flying on the SSRI, I can think of at least a dozen others who have entered treatment and not had to go on it for life, yet because that was available, were willing to go and seek counseling, seek help that was needed. So I want to thank you. It really does make a difference. The question I have, though, that goes with it is NIMH, National Institute of Mental Health data, suggests that the numbers should be significantly higher than we're seeing. We're seeing the numbers in the double digits, and it should be more for a large pilot group. What can you do to help us help identify those people so that they get the help that they need so that they can return? Because everyone who does seek it out eventually does return, or virtually, in our experience.
That problem worries me. It's one of the things people say keeps me up at night. And the reason it keeps me up at night is I think we are probably more conservative than we need to be. If you're aware of the standard that we have, we require a person to have been on the medications for over a year, to be stable for over a year, and that's the biggest concern. And the reason we did that is because we want to make sure that we don't certify someone and then find out down the road that that was a mistake. And probably the best example of that is a medication called Chantix that was used and still is used to prevent smoking. And we actually certified people on Chantix for a while, and then we started finding out, in fact, the FDA put out a notice called a black label notice that said those people were having a significant increase in suicidal tendencies, in some case actual suicide. And we had to go back and uncertify all those people because we were concerned that suicidal ideation, or actually suicidal acts, was not a thing that we should safely certify people for. So when we went from not certifying people with depression and certifying people on antidepressants, we were concerned that we wanted to make sure we did it right. Although we think that in the long run we will reduce the year to some shorter period of time, and also even our regulations now, we only certify 4 different drugs, although we have said that if we find other medications, and I'm certain that as medical science improves medications and improves the research, that we'll find other even better drugs and medications than the one we're using now that will increase the number of medications that individuals can use and be safely certificated. The other thing is the year-long period that makes people wait. Some of them say they either have been taking them and say, well, I know that other people are certified, so it's probably okay for me to continue to do this and not report it because I know I'm going to lose my longevity for some period of time. So that's kind of a disinhibitor that we have that convinces people that they shouldn't be acknowledging those. Some other people might say, I understand that I have to wait a year, I'm depressed, but I can't afford it, or I don't want to be disqualified for some period of time, and so they're flying in a depressed state, which is also not good. So I'm looking at better ways to certificate people, to give more people an opportunity to get certificated if they need it, to reduce the certification time that they require to be on the medications so that we can offer this to more individuals. Because I agree with you, the data of the number of people that are certificated probably are not equal to what the number are in the normal in the non-certified, non-flying population. And so I think there are people that need to get an opportunity, and we're working on ways to do that.
Again, I just want to say thank you, because it has made a difference in many, many lives of people that we've worked with. So thank you.
You're welcome.
Good afternoon, gentlemen. Ray Jelena, ALPA Investigation Board member and line captain for Jazz. This question for Dr. Snyder. As you know, we represent pilots in Canada and the U.S. I'm wondering if you could elaborate on your relationship with our regulator in Canada, Transport Canada, and if you could elaborate on any appeals to the Transportation Appeals Tribunal in Canada and any denials you may have seen there that might have been certified in the U.S. or vice versa, if you're aware of any differences.
Sure, I'd be happy to comment. Our Canadian brothers and sisters are very, very independent. The calls that we get from Canadian pilots usually relate to the effect of medications, surgical options available, different types of treatments, or policies with respect to the FAA. In Canada, you have a much closer relationship with your CAMEs, what we would call aviation medical examiners here, and the RAMOs, which are our equivalent of regional flight surgeons. There seems to be a very collegial interchange of information. Also, Mr. Dave Noble from Toronto does an absolutely fantastic job in coordinating the resources that our Canadian ALPA pilots use, and has been very successful. We don't have direct interactions with Dr. David Salisbury, who's the gentleman who heads up, who's Fred's equivalent up in Canada, on individual cases. We do communicate with him on policy issues, but I can't give you any data on individual cases where denials have been appealed to him, done through our office. Mr. Noble and Murray Monroe are the gentlemen who coordinate that.
Thank you.
Hello, gentlemen. Stephen Flesh, ASO Communications Coordinator. I just wanted to briefly ask you, I know we touched on the risk of melanoma that pilots are maybe starting to see. And just talking with other line pilots, there's the thought out there is that the windows in the cockpit of our aircraft should be protecting us from sun damage. And I wanted to see if you had any guidance for us or opinion among the AME community that perhaps those windows are not protecting us and we should be seeking extra protection using sunblock, that sort of thing, to protect us from not only sun damage but perhaps melanoma as well.
I don't think this is so much an AME question as it is a general health question. Probably if you walked around with black clothes and under an umbrella from the time you were age 6 months or when you could start walking, you'd be better off than if you didn't do that. And we see, and what Dr. Snyder said earlier was that we're not sure whether the risk that pilots have is attributable to being in an airplane or the fact that they may have more leisure time when they're lying on the beach somewhere sunning themselves. I know when I was young, which was when they were wearing blue and gray uniforms, I used to go out every day in the sun and I didn't wear sunblock and I would get baked, and then by the end of the summer I'd be brown and tanned and the sun didn't seem to bother me, but I was still cooking myself in the sun, and people in my generation grew up that way. I strongly recommend that people wear sunblock when they go out in the sun, even if they're there for a short period of time. I recommend that people wear hats, and I think everyone should do that regardless of their occupation. So I wouldn't say so much that I would recommend for pilots necessarily that they wear sunblock, other than I would recommend that everybody wear sunblock and protect themselves from the sun. Now, that doesn't mean I think you should be a monk and live in a cave and never go out in the sun, because you even need the sun for vitamin D production. So the sun is not a bad thing, but you need to do, like you need to do everything else, you need to moderate what you do. And when you go out in the sun, you should wear clothing unless you're bathing, obviously, and you should wear sunblock to protect yourself.
I think also the physics are that the UVA, UVB is adequately screened through the cockpit windshield. We worry a little bit about what penetrates, the heavy particles that penetrate, such as protons, when there are solar flares. But if we were successful in getting some sort of responsibility, either through OSHA, the FAA, the companies, in doing dosimetry studies of pilots, we would have a much better idea of what the true radiation exposure is, and then we can compare that to known data that we have to try to make an estimate as to the risk for certain types of cancer. But at this point, we just don't have that data.
Is there an interest in collecting that data soon, or has there been kind of a pushback from the industry, do you think?
There's an interest, and I would encourage you to pick up a copy of the ALPA white paper that I alluded to in my opening remarks regarding occupational safety and health for pilots, with a proposal from ALPA to create a partnership between the FAA, OSHA, industry, and labor to see if we could get that both instituted and then monitored and then perhaps action based on the results of that. At this point, it doesn't exist.
Thank you, gentlemen.
I'm Bill Edmonds on the ALPA Air Safety staff. First of all, Dr. Tilton, I'm really sorry to hear about Wally Friedberg's passing. He was always a very knowledgeable individual and a go-to person for any questions we had on radiation issues, and we appreciated his expertise being available to us. The FAA and ALPA and the industry have had a long history of collaboration on a number of issues. Dr. Snyder mentioned the HIMSS program, which goes back over 35 years to help people or pilots with issues in regard to alcohol, substance abuse. Dr. Tilton, I'm wondering if you could share with us any thoughts you may have on collaborative efforts that the FAA and ALPA could enter into to assure and improve pilot health and safety?
I guess the best collaborative effort that I'm aware of right now is what we have with Dr. Snyder and his group. I mean, he represents not only ALPA, he represents other organizations as well. And their philosophy, and in fact, you may or may not be aware that none of his doctors are AMEs, aviation medical examiners, because they want to have no idea that there's a conflict between them as designees versus people that actually support the organizations they work with. Not to say that that doesn't mean that they're fully qualified and competent to do that if they wanted to be. They certainly know all of our regulations, and they understand why we do things. But as I said earlier, we meet with them quarterly, and frequently we get calls from them. I talk to Quay not weekly, but quite frequently about specific cases, specific issues, specific concerns that he and his group might come up. I also do that with EAA and, as I said, AOPA as well. So the collaboration that I see is having people with medical knowledge that understand what's going on in the community, working together to find whatever science we can to make sure that what we're doing is safe and what we're doing is the right thing for the safety of the community and also the pilots that operate in it. So I don't have a better answer than that, because there aren't a lot of individuals that have not only the expertise in the science, but also the expertise in aerospace medicine. If you look at our doctors in the FAA, we have over 15 individuals who are board certified in aerospace medicine. Dr. Snyder's group are all that way. And so we understand not only the science of the medicine, but also the science of the way that the particular issues interact with someone when they're in a cockpit or in a cabin or maintaining airplanes on the ground, so that using that expertise and that information, we do the best we can to certify as many people we can, but do it safely at the same time.
Thank you. I think the great example that you brought up, Bill, was the HIMSS program. It's been in place intermittently since 1974. The FAA funds the program. They provide the funds, which is administered through ALPA, to educate the entire airline industry as to the disease process of alcoholism and substance dependence, and define a way to readily identify, intervene, treat, rehabilitate, return to flying status under a rigorous monitoring program. But without the FAA support, we would go nowhere in that. And what we're seeing is that other international organizations really want what the FAA has established with ALPA. They want information on how do we do this, because before the problem was underground. As Fred said, if you had hypertension when he was wearing his blue and gray uniform, I don't know if he was a blue or a gray guy, but when he was wearing that uniform, you were disqualified. Certainly, the name HIMSS, Human Intervention and Motivation Study, comes from back in the 70s when you couldn't say airline pilot and alcohol in the same paragraph or even in the same paper. The name has stuck. The effectiveness has just increased and it's spread. But it's done in close collaboration with the FAA, with the airlines, and support from their management and from the pilot unions, and then also the aerospace medical community. The FAA trains a very limited number of physicians through our HIMSS program who are qualified to serve as sponsors with that. And those same physicians who are qualified to serve as independent medical sponsors for the pilots in recovery are the same ones that provide the scrutiny that the FAA requires for the people on the SSRIs as well. It's a great program, it's tremendously successful, and it's probably the premier example of cooperation and collaboration between the FAA and industry.
Great. Thank you.
Hello, Dr. Tilton. I'm Jesse Cooling. I'm the PSA MEC chairman. Earlier you alluded to other countries certifying pilots with medical conditions such that they would only be able to fly with another crew member, which is I'd never heard of before. I was interested to know if, one, if there are any studies in the number of instances of incapacitation on that basis versus the sort of single pilot basis that you said that we're using, and then further, if the FAA has considered using that standard going forward, maybe based on shortage of pilots and things that we'll need to cover that.
I don't think there are any specific studies that have done to show that. I really, frankly, believe that I'm not sure how it would help if we, well, let me say it differently. When I used to go over to Europe every quarter and talk to these people, I would argue about the fact they were unnecessarily disqualifying people, people that we felt were certainly safe to fly, people that we would qualify on a special issue, for instance with stents or with the bypass surgery. They were very conservative, and they would not let those people fly unless they had another person in the cockpit. I can't think of an instance where there was someone that they qualified that we wouldn't have qualified to be in a two-person cockpit. So what I think is they were unnecessarily restricting people so they couldn't fly by themselves. And by that I mean by themselves, without someone else in the cockpit who was fully qualified in case they had a medical condition. So I can't think of a situation that would cover the question you have, which is, could we get more pilots in the cockpit if we made a decision to certify people restricting them? We also actually, years ago in the 90s, were prevented from putting restrictions on first-class pilots because we lost a lawsuit in which we were restricting flight engineers that they could only fly, they needed a first-class certificate, but they could only fly as flight engineers, and we lost a lawsuit, and now it says we can't restrict a first-class certificate. So there's legal precedence to say we can't do it. Plus, I really believe when I talked to my counterparts in Europe, they were overly restrictive and didn't need to do what they were doing.
Thank you.
I would say that the FAA, you have a better chance of having a medical certificate in the United States than any other country in the world. There are a few exceptions, as the SSRIs before, or perhaps with insulin requiring diabetes in Canada. But the evidence-based medicine policy has allowed a liberalization of the standards and the waivers that pilots get, and we're just thrilled with the spectrum of that. There have been some studies about in-flight incapacitation, but it didn't discriminate between 2 pilot crews and 1 pilot crews. But I believe that there's never a reported accident in the United States, aircraft accident in the United States, as a result of incapacitation in flight in a commercial situation with a 2 pilot crew. But the Aerospace Medicine Association has published 2 studies over the last 12 or 13 years, I believe, on reported in-flight incapacitation that gets called into the FAA as crew member incapacitation and then goes through the normal investigative process.
And just one other comment. I really believe today, and I tell people when I was flying C-141s, we didn't have an FMS. Essentially, we were flying a big airplane. But I felt pretty confident that if something happened to my co-pilot, I could go ahead and take over and land that airplane and talk on the radio and do all the stuff I needed to do. But in today's world, as you're well aware with flight management systems and programming and the way we fly airplanes now in our airspace, if you take a 777 and fly it into Heathrow and you're in weather, that's really a 2-pilot operation. The second pilot is not there to make sure that if the other pilot's incapacitated, he can land the airplane. He's there, and he or she has a specific responsibility, and they're necessary in order to safely operate. Now I know airlines do incapacitation training, and I support that. I think it's great because we do have cases where people are incapacitated, but that's not optimal. And I'd much prefer to have a situation where both pilots are fully qualified and medically competent when I'm flying in situations such as I just described.
Any more questions out there? Is everybody satisfied and happy?
Or asleep?
All right, then I guess we'll wrap it up. I want to thank our distinguished guests. Thank you, Dr. Snyder and Dr. Tilton. And again, thank you for all your inquisitive questions. So, thanks and have a good day.